Kia ora koutou, and welcome to tonight's Goodfellow webinar titled ARF, Don't Miss That Diagnosis. My name is Pulasti and I'm a GP based in Central Auckland, and I have the pleasure of inviting our guest speakers for tonight. So our panel tonight includes Dr. Barnett Bond. Barnett is a GP at the Calder Centre of the Auckland City Mission. He is a chairman of the Auckland Rheumatic Fever and Rheumatic Heart Disease Group and a GP liaison for Starship Hospital. Next, we have Marianne Ross, who is a rheumatic fever nurse specialist. She's one of the cardiology nurse specialists for Te Tukatumai, Auckland, and works in the rheumatic fever and rheumatic heart disease service area for both Auckland City Hospital and Starship Children's Hospital. And finally, we have Associate Professor Nigel Wilson. Nigel works at Starship Children's Hospital in Auckland. For more than 30 years, he has split his time between working as a frontline cardiologist and researching groundbreaking ways to help fight rheumatic fever and rheumatic heart disease in children. So without further ado, I'll hand over to our speakers. I believe Barnett is going first.
Okay. He ana koutou I tēnei ahia. Mai ngā iwi maha, ko taki te iwi. So I'm Barnett Bond, chairman of the Rheumatic Fever Group, and you should have a pen and a pad beside you because there's a quiz embedded in this talk. Only you will know your score, but you should do the quiz. Some of the questions are easy, but you will need to write fast. Throughout this talk, I'm going to call one bacteria by two different names. We know it as gas or group A streptococcus, but it's otherwise known as strep A. Sometimes it has a third name, strep pyogenes, but I'll not use this name tonight. The international consensus has moved away from gas, group A strep, and favours calling it strep A, but I'll be using both names in this talk. So let's begin at the beginning. We need your help. New Zealand has a persistently high rate of acute rheumatic fever. If this diagnosis is made in time, then heart valve damage is avoided, and if the diagnosis is missed, some children will develop valvular heart disease and some will die. If you're practicing in the North Island, then sooner or later a high-risk Pacifica or Maori child will be brought to see you with a sore throat or a sore knee or a sore ankle or a rash. The diagnosis of acute rheumatic fever is missed often by us in primary care, by ED doctors, by everyone. Why is this? It's partly because occasionally the presentation of acute rheumatic fever is atypical, but sometimes the diagnosis is blindingly obvious. It's dished up to us on a plate. The signs are as clear as a summer's day, and we just don't see it. Or we tie ourselves in knots with the Jones criteria, and without appreciating the transient nature of some of these criteria, we miss the diagnosis that way. This seminar will show you a new approach so that you don't miss the diagnosis. This is the sequence. If you miss the strep sore throat and then later you miss the acute rheumatic fever, then some of your patients will wind up with rheumatic valvular heart disease, and between 5 to 10 of them will die every year. Let's look first at acute rheumatic fever and then at rheumatic heart disease and see what we can do about this. Acute rheumatic fever, it's preventable. Who can prevent it? You can. Every primary care doctor, every nurse, every pharmacist can prevent this disease, but you're going to have to become much better gas and ARF hunters than you are right now. Gas and ARF, GAS, gas, group A streptococcus, or now known as strep A, and ARF, acute rheumatic fever. So here's the first quiz. Grab your pen and pad. All of these people have been vilified by the press as public enemy number one. The questions, 4 questions, who are they? Just to be clear, the public enemy in the top left is the woman. In the top right, it is both the man and the woman. And in the bottom right, this is an AP and a lateral police photo of the same person. Write their names down on your pad, numbered 1 to 4. You've got 20 seconds. Okay, so the question number 1, the woman in the top left is Camilla, or I should say Her Royal Highness, Camilla Parker Bowles, Camilla Windsor. In the top right, Bonnie and Clyde. bottom left, Donald Trump, bottom right, Al Capone. But these are not the real public enemies, are they? Here's the real public enemy number one. Quiz time again, question 5. Write down the current name and the new name of this bacteria. You've got 10 seconds. Well, this was an easy one. I already told you this. Group A Streptococcus, or Strep A. And pictured in the middle of this slide is a chain of 4 orange-coloured Strep A's labelled gas, busily making a range of weapons. They use these weapons to attack human cells, particularly white blood cells, red blood cells, cardiac muscle cells, and they also make other weapons that enable it to evade our patients' immune systems. So quiz time again, questions 6 and 7. There are 10 weapons pictured on this slide, circled around the group A Streptococcus. Scan them quickly and write down the names of the 2 that we can test for in our local lab. So there they are. If you've got streptolysin O and anti-DNAase, you can take a mark each. Acute rheumatic fever is a notifiable disease. So let's look at the notifications to the Auckland Regional Public Health Service for 2023. In each of the quarters of 2023, an average of 23 confirmed or probable cases of ARF were notified to the Auckland Regional Public Health Service. The second quarter was particularly bad with 34 cases. The cumulative case numbers for 2023 ended up being similar to the 2017-29 average, which was high. Case numbers in Auckland were much lower in the COVID years of mid-20 to late 2022. So what do we know about those 34 patients from Q3? Well, the first blue bar tells us they were all young. The second green bar tells us that 24 out of 34 of them lived in counties Manukau. The third bar says they're all Pacifica or Maori. And the last bar tells us the suburbs they live in. Here's a heat map of the last 10 years of patients with acute rheumatic fever, and most of last year's cases live in precisely the same South Auckland suburbs as the cases of the previous 10 years, and most of them attend a GP practice near their homes. But for those of you who are in Northland or Hawke's Bay, Capital and Coast, etc., this is not the time for you to let your guard down. So here's the North Island of New Zealand, and the darker the shade of green, the higher the incidence of acute rheumatic fever. But if you practice in Taranaki or Wairarapa, which are the white areas on those maps, don't relax. The past might not predict the future. While most past cases are in Auckland, so is most of the New Zealand population. And here are the 34 patients in question. Some were diagnosed early and some were diagnosed late. Let's have a look at the case of the lass in the orange hoodie in the second row. This is Tuavala. She's 15 years old. She lives with her parents and siblings. There's 8 family members in a cold house. One sister has bronchiectasis and another sister had severe acute rheumatic fever. I'll read that last sentence again. Another sister had severe acute rheumatic fever. Mother asked the GP if Tuavala's 2-week history of sore knees might be acute rheumatic fever because of her experience with Tuavala's sister. The GP said no, this was not acute rheumatic fever, and gave mother a pamphlet on acute rheumatic fever. And the GP's notes from the day record impetigo. The GP nurse's notes on the same day record sore left knee last week and now sore right knee. Both the GP and the nurse recorded no sore throat. There was a prescription for Augmentin for 5 days. We don't know whether Tuavala took it, but what we do know is that 1 month later she had ankle pain and could not walk. Mum took her to a different GP. That GP got some blood tests. The SGOT was 1,043. The anti-DNAase was 500. Tuavala was short of breath and had not been able to run in the playground at school for several weeks. This GP noted a grade 4 out of 6 systolic murmur, loudest at the apex, and sent her into hospital where she had cardiac surgery for severe mitral regurgitation. She'll be on warfarin for life and monthly penicillin injections for the next 10 to 20 years, and she's got a scar on her chest that looks like this. All the children who emerge from cardiac surgery have scars that look like this, but the scar's not the big deal. The big deal for her will be remembering to turn up for monthly painful injections for the next 10 plus years. And if she has a mechanical valve, she'll also have to remember to take warfarin for the rest of her life and have the weekly to monthly blood tests that go along with that. When they become teenagers, some of our patients stop taking their warfarin and they die. Most of the rest of the developed world has eradicated rheumatic fever. Cuba and Mozambique and Costa Rica have all but eradicated rheumatic fever. New Zealand is a first world country, but it's got persistently high rates of this third world disease. So in 2012, the Ministry of Health set a national target to reduce the incidence of rheumatic fever by 2/3 to 1.4 cases per 100,000 people. So how are we doing? Well, this is a busy slide, but we only need to look at the left, the column down the left, which is the years. If there's a decade of them, 2013 at the top and 2023 at the bottom. And then look over to the other side of the slide where there's a bunch of numbers in red ink, headed with a heading IR, which stands for incident rate per 100,000. And you can see in 2013, it wasn't very flash at 5.8. And if you cast your eye down the list, you can see that the numbers bounce around between 3 and 4, except for the COVID years, which you can see they're a bit lower, and then back to 2023, where we're back to 5.2 again. Now, remember, these numbers are likely to be underestimates because they rely on physician notification with no laboratory component, and compare that with meningococcal disease. In fact, even invasive group A strep is not a notifiable disease in New Zealand. We hope that might change. Numbers on a busy table are a bit hard to follow, so here's the same data on a graph. The light green line that's second highest on the graph is 2017-19 average. The next line down, which is a bit darker green, is 2020. Then the lowest number of notified cases are the two bottom lines, which are, of course, the COVID years of 21 and 22. But look at the back at the top, very top line, the dark blue line. It shows the highest cumulative monthly count. This is 2023, and it's heading for the stratosphere like one of Elon Musk's space rockets. This is Samuel. He's 6 years old. He had a one-day history of a sore ear, a sore throat, and body aches. And then he had body jerks. And the babysitter was worried about the body jerks, so she called Mum, and Mum came home from work and was worried as well, so she called the ambulance. And the ambulance took Samuel to Middlemore, and in the ambulance his temperature was 38.8, and in ED he was observed for 2 hours, and a diagnosis of pseudo-seizures and a viral urticaria was made, and he was treated with Panadol and ibuprofen. He went home. We know nothing after that, except we do know that 10 months later he presented again with right elbow pain, and then left ankle pain, and then right ankle pain, and then shortness of breath, and then shortness of breath lying down, and then chest pain. He never had a rash, he never had nodules, and he had a negative throat swab. And he was admitted to hospital where an echocardiogram showed mitral regurgitation. He had open heart surgery with a mechanical valve. Here's what mechanical valves and tissue valves look like. This is a mechanical valve which will have come from Medtronic and will have flaps made of carbon or titanium, which are attached to a Teflon or polyester ring. And this is a pig valve implanted in the mitral position. It's been mounted in a frame reinforced with Dacron. Abbott Labs market this particular modification, which has been treated with an anti-calcification preparation, because all biologic valves suffer from progressive tissue degeneration and they need replacing because they fail at between 10 to 15 years. Typically, pig valve replacements wear out faster in younger, more active individuals, namely our group of patients who you met 3 slides ago. And you can do the maths yourself to work out how many times these patients will need cardiac surgery in their lifetime to replace the valves if they get replaced every 10 to 15 years. But let's get back to the 6-year-old Samuel. And here's another question, question 8. What were those jerky movements that Mum and the paramedic observed and that persisted throughout the time in ED and were called pseudo-seizures in ED? So if you wrote Sydenham's career, you can take a mark for question 8. So here's the first surprising take-home message. Preceding group A streptococcal sore throat is the cornerstone of the diagnosis of acute rheumatic fever. We read that everywhere. We read it in the National Heart Foundation guidelines in our pathways. But neither of these patients had a sore throat, or if they did, it was long ago and they'd forgotten. Tuavala was asked about a sore throat, and she answered no. So should it be that a sore throat has to be part of the diagnosis for all children when some children forget that they had a sore throat, especially if it was long ago? We'll come back to this point shortly. So now we come back to the claim I made at the beginning of this presentation, and you might be beginning to have your doubts that this disease is preventable, but I've shown you these two cases only to convince you that we need a new way of thinking about our patients. The considerable efforts of the last 10 years have made almost no difference to the incidence of this disease. And as Henry Ford said, if you always do what you've always done, you'll always get what you always got. So here's a new plan to prevent almost all cases of acute rheumatic fever and to spot the few that slip through the net so early that they suffer no irreparable heart damage. You already know this. You know there's a definite sequence starting with untreated group A strep's throat infections leading to acute rheumatic fever and that leading to rheumatic heart disease. But let's start at the bottom of this slide and look back from all the patients with chronic valvular heart disease that come into Starship and see how many of them presented to their GPs or someone else with acute rheumatic fever. And this slide says only 50%. Well, that's a surprise. Perhaps a little more, but about 50% of the kids with heart disease presented with a history of clinically recognizable acute rheumatic fever. That makes life difficult, doesn't it? Is it possible that the other half had subclinical rheumatic fever sometime in the past? Or could it be that strict adherence to a set of major and minor criteria makes us miss the diagnosis? Well, let's look at the Jones criteria now and see how well they perform in the real world. And here are the Jones criteria, and they're very similar, although slightly different from the New Zealand Heart Foundation criteria. But what's clear from both is that 4 out of 5 of the major criteria and 3 out of 4 of the minor criteria are transient. That is, they might be present on the day that you examine the patient, but then again, if the primary infection was many months in the past, they might have resolved. For example, on the major criteria side of this slide, arthritis can subside within a few days and almost always within a few weeks. Subcutaneous nodules last typically for a few weeks. On the minor criteria side, fevers subside. ESRs and CRPs don't stay elevated permanently. White cell counts return to normal. And there's another box on the slide at the bottom headed diagnosis. And according to Jones, the first item is that you need to show evidence of group A streptococcus either by a positive throat swab or in the situation where the sore throat's in the past and has been forgotten by positive serology. So it's beginning to look like the Jones criteria have high utility for making a positive diagnosis, but you can't rely on them to confidently rule out acute rheumatic fever. Pick up your pen. It's quiz time. What are pictured here? Question 9 is in the top left. Question 10 is the top right. Question 11 is the bottom left. That's both pictures in the bottom left. And question 12 is on the bottom right. Okay, so question 9, arthritis. Question 10, subcutaneous nodules. Question 11, both pictures, mitral valve vegetations. And question 12, that's the rash of erythema marginatum. So here's a bonus question. Where are the nodules seen? And where's the rash typically seen? And I'll tell you the answers to those at the end of the presentation. So let's have a look at this lass who's in bed with a fever of more than 38, which is a minor Jones criteria. And let's go around the little pictures in circles clockwise. Erythema marginatum is a major criteria. but it's very rare. Heart murmurs, this is a very late sign, and the whole point of this evening's seminar is for all of us to make the diagnosis of group A strep and acute rheumatic fever much earlier so as to head the carditis off at the pass. Painful joints, this is easily the most missed symptom in all the cases we see at Starship because it's regularly confused with a sports injury, septic arthritis, or growing pains. So, the Jones criteria are an important tool, but there is a better starting point, and your regional health pathways have a different starting point. Let's have a look at them because they start instead with red flags. And here they are, rheumatic fever and rheumatic heart disease, red flags. And the first red flag is in fact the one that's above the flag, being Maori or Pacific. And then we go down to painful or swollen joints. Well, Tuavala told her GP she had sore joints. Samuel told 2 GPs he had sore joints. The next flag, limping or unable to weight bear. Well, Tuavala's joints were so sore she was unable to run. New or changed murmur. Well, Tuavala had a heart murmur. Next, choreiform movements. Samuel had choreiform movements. Next, shortness of breath and heart failure. Well, Samuel and Tuavala both complained of breathlessness and were almost certainly in heart failure by the time the second or third doctor saw them. So what weight should we put on these red flags and how do they fit with the Jones criteria? Well, the red flags require immediate attention. Red flags say act now to stop the train going over the cliff. Red flags should make you immediately assume that ARF is the diagnosis and work to either confirm or eliminate it. Let's take an example. Say we're not sure whether our 15-year-old Samoan patient has or had arthritis, which is a major criteria, or arthralgia, a minor criteria. The red flags say limping requires immediate attention. The red flags say painful joints require immediate attention. So here's the new plan. In a Pacifica or Maori child with 2 or 3 high risk factors who's limping or complains of other painful joints, especially if the joint pain has migrated from joint to joint, then swab their throat if it's sore or do strep serology if it's not. And if either result is positive for strep A, contact the on-call pediatrician or physician at your hospital and let them help you sort out the diagnosis. This is much safer than deciding that the sore joint is probably related to the netball injury or the rugby injury and sending the patient home without a throat swab or strep serology and having the train go off the cliff. And remember, Tuavala was automatically high risk without even relying on the 2 out of 3 rule because she had a sister who had acute rheumatic fever. If you're a GP in South Auckland and Middlemore, Kids First is your hospital, there's 2 different cell phone numbers to phone. If you're not sure of which one to phone, email me after this presentation and I'll send you that slide. Here's page 2 of the pathway about rheumatic fever and rheumatic heart disease. Acute rheumatic fever is an immune-mediated acute inflammatory illness occurring in susceptible people following an untreated group A streptococcus infection. It usually occurs 14 to 21 days after infection, but can be more rapid. 0.3 to 3% of untreated or incorrectly treated gas infections will go on to develop ARF. Oh, that doesn't sound too bad, does it? 0.3 to 3% of untreated gas go on to develop ARF. 97 to 99% don't. Let's look at the next sentence, though. The more times a patient has a gas infection, the more exaggerated the immune response and the higher the risk of developing ARF. Ah, so now I see. So if the patient has 2 missed group A strep throat infections, their risk of going on to developing ARF isn't 3%, it's 25%. And if they have 3 missed group A strep throat infections, it's not 25%, it's 75%. So say this is something we'd definitely like to pay attention to. Most of us GPs would have mixed feelings about missing the diagnosis of group A strep and or letting our Pacifica children with group A strep throats progress to ARF. Most of us would instead be very keen on a spot of primary prevention. So here's the sequence. Untreated gas sore throat goes to acute rheumatic fever in 3% of first-time missed sore throats, 25% conversion if there's 2 missed sore throats, and 75% if there's 3 missed throats. So primary prevention starts where the red arrow says it does. Let's have a look at the pathways. What does the pathway say? Primary prevention of acute rheumatic fever includes early diagnosis and treatment of group A strep throat infections with a full 10-day course of appropriate antibiotics in people most at risk of ARF. So let's skip down to the red arrow and see who these people who are at most at risk of ARF are. And it says, people who are at most at risk are those with a personal, family, or household history of rheumatic fever, or if they have 2 out of 3 of the following: they're Maori or Pacific, they're aged 3 to 35, and they're living in crowded accommodation or in deprivation. Here's the same information in a much easier to read format. Your patients who are at high risk are anyone who's had rheumatic fever before, anyone who has a family member who's had rheumatic fever, anyone who lives in a house with someone who has or had rheumatic fever, or 2 out of 3 Maori Pacific 3 to 35 overcrowding. So if we go back to the primary prevention slide and look at the sentence that I missed the first time through, and it's now marked with a red arrow, and it says in high-risk groups, up to 2% of young people will have asymptomatic, undiagnosed rheumatic heart disease. I'll read that again. In high-risk groups, up to 2% of young people will have asymptomatic, undiagnosed rheumatic heart disease. That's rheumatic heart disease. That's not acute rheumatic fever. So if 100 high-risk kids walk through your door over the next 6 months, 2 of them will have carditis, asymptomatic, undiagnosed carditis. You might be able to detect it with your stethoscope, but it might require an echocardiogram to detect it. These kids must have had 1, maybe 2, maybe 3 unrecognized and untreated episodes of group A strep sore throat. They'll not have had a throat swab. They'll not have had penicillin. And now they have rheumatic heart disease. So let's get back to last year's kids. Every one of these kids had 2 or 3 risk factors and were therefore high risk. The good news is that many of them saw a GP who recognized that they were high risk and took a throat swab or did serology, suspected the diagnosis and sent the patient into hospital, where the ED doctor agreed that an echocardiogram was indicated as per the New Zealand Heart Foundation guidelines. The bad news is that in spite of being high risk and having in some cases a red flag, some of these kids saw several doctors who missed the diagnosis, and for these kids, their train went off the cliff. So, Primary Prevention 2024. From now on, you're going to ask lots of questions of every high-risk patient or their parent. Every Pacifica or Maori between the age of 3 and 4 and 35 who comes into your office for any reason, always ask, how many people live in your house? Have you had a sore throat at any time in the last month? Have you had a sore joint or a limp recently? They might come in with impetigo or asthma or a viral urti or eczema or diarrhea or anything. If they are high risk, always ask, have you or anyone near you ever had rheumatic fever? Have you had a rash? Are you tired all the time? Have you had time off school through sickness? This is Alana. She's 9 years old. She's Samoan. She had a confirmed group A strep infection in January. We don't know whether she took a proper course of penicillin. There's nothing in test safe. We assume she got better. Then 3 months later in April, she went to her GP complaining of monoarthritis in her right knee and she had a fever. This GP sent Alana straight to Starship with a provisional diagnosis of acute rheumatic fever, query, infective arthritis, query. The Children's Emergency Department called the peds orthopedic surgeons who washed out her knee and cultured the synovial fluid, and that was cultured negative. So the orthopedic surgeon did an ECG. Now I know that sounds surprising, but the orthopedic surgeon did an ECG, and he noted a junctional rhythm. The CRP was 118, the ASOT was 370, and the anti-DNAase was 353. So the orthopedic surgeon referred the patient to cardiology and asked them to consider an echocardiogram, and cardiology declined, stating there was limited evidence for acute rheumatic fever at that stage. Really? Limited evidence? Let's see what the New Zealand Heart Foundation guidelines have to say. Any person with suspected ARF should have an echocardiogram shortly after admission to hospital. Why? Because echocardiography reveals between 16 and 47% more cases of carditis than your stethoscope can. So if you have a high-risk patient with one red flag, especially arthritis, and you send her into hospital and they decline to do an echo, phone the consultant in charge of the case and discuss your understanding of this page of the Heart Foundation guidelines. And it's not just the New Zealand Heart Foundation guidelines that say this. Here's something from the European Journal of Echocardiography. If the pre-test probability of carditis is high, then echocardiography must be performed as early as possible. Was Alana high risk? She was Samoan. She was 9 years old. She had a history of group A strep infection in February 23, and she had arthritis, real arthritis, not arthralgia. So what went wrong here? Ortho requested an echo and cardiology declined it. It looks like a slam dunk indication for an echo to me. This must have been a communication failure because there's clearly a high suspicion of rheumatic fever. So take-home message, if something unexpected like this happens to one of your patients, phone the consultant and discuss. But here's some good news. The Blue Arrow Brigade in this slide saw GPs who recognised that the provisional diagnosis was acute rheumatic fever, took throat swabs, which were gas positive, sent these patients to hospital where the ED doctors agreed that an echocardiogram was indicated as per the Heart Foundation guidelines, and the patient was admitted. The bad news is that in spite of being high risk and having in some cases a red flag, the others, that's the no Blue Arrow Brigade, saw several doctors each who thought it was a different diagnosis, and for those who got cardiac valvular damage, their trains went off the cliff. This slide is from the National Heart Foundation guideline about in-hospital management. It's for in-hospital doctors, so we're not going to talk about it except to draw your attention to one line right in the middle under that first red bar, which says, ideally, all those with suspected acute rheumatic fever should be hospitalized as soon as possible after the onset of symptoms, and the slide goes on to give the reasons. Let's get back outside the hospital and into our practice and into our surgeries. This slide is also from the New Zealand Heart Foundation website, and it's titled The Sore Throat. Tuavala and Samuel showed us that sore throats are not present in every case, but they are present in most cases. But GPs see heaps of sore throats, and they're almost always viral, aren't they? Don't treat sore throats with antibiotics. That's the message from VPAC, isn't it? Well, it's really very simple. Follow the large red arrow in this slide and do treat the high-risk patients with a sore throat with penicillin, and follow the large green arrow and don't prescribe antibiotics for the low-risk patients. And who are those high-risk patients? Well, here's a laboratory request form, and every time you go to fill in the lab form for a throat swab, the form tells you who the high-risk group, and it's the same group we already know. You can see the words high risk in the middle of that slide: personal, family, household history of rheumatic fever, or the 2 out of 3 criteria. It goes on to make you write down the high-risk category for the patient in question in the free text field at the bottom under the words indication. So not only do antibiotic-resistant considerations dictate that we not treat low-risk patients with antibiotics, but the labs don't want to waste the taxpayers' money culturing throat swabs from low-risk patients. So here it is again, a bit easier to read. Anyone who's had rheumatic fever before, family member, living in a house, or 2 out of 3 of Maori Pacific 3 to 35, living in an overcrowded house. And what are the National Heart Foundation guidelines? What's their advice to primary care? Well, looks like just 2 things. Thing 1, take a throat swab. Thing 2, start the penicillin. Don't wait for the swab result. The guideline used to say you could safely wait up to 10 days before starting the penicillin. This is no longer believed to be wise. Start the antibiotics straight away. And now you've diagnosed a patient with group A strep throat infection. Who else is in close contact with them that might also be harboring group A strep? Well, this page from the New Zealand National Heart Foundation says that you should swab everyone in the same house who has symptoms. But where there's been previous acute rheumatic fever, then everyone, that's everyone, those with symptoms and those without symptoms should be swabbed. or where an individual has had 3 or more group A strep throat infections, or there have been 3 or more household cases, then everyone should be swabbed. Those with symptoms and those without. Similarly, if there's an outbreak in a school or a workplace, everyone should be swabbed. Remember the slide about primary prevention. And the high-risk groups, in that group of patients, 2% will have asymptomatic, undiagnosed rheumatic heart disease. So what are we going to do about them, and how are we going to find them? Well, back to public enemy number 1 and the bits and pieces of evidence that he leaves lying about that tell us he's been there. And we can test for some of these bits with the ASOT and the anti-D and ASB. If you're suspicious that your patient has had GAS recently, but the throat swab's negative, then the ASO antibody serology and anti-D and ASB serology might provide evidence of a recent group A strep infection. And then there's the acute phase reactions, such as the ESR and the CRP, and they are usually elevated at the onset of acute rheumatic fever, and they serve as minor manifestations in the Jones criteria. But remember, these tests are non-specific. You can do blood cultures if you're worried about endocarditis. But remember that no single specific lab test can confirm the diagnosis of acute rheumatic fever. It remains a clinical diagnosis. The red flag should alert you to assume the diagnosis, and the Jones criteria can help you confirm, but not refute it. If the combination of test results and criteria don't give you a clear diagnosis, phone the pediatrician or physician at your hospital and discuss. Most common finding on electrocardiogram is a prolongation of the PR interval, which is a non-specific finding, but it counts as a minor manifestation in the Jones criteria. It does not count as proof of carditis. Okay, so the next slide is back to quiz time. Pick up your pen. What are the main reasons for treatment failures? Write down three reasons that you can think of in 30 seconds. These are questions 17, 18, and 19. What are 3 reasons for treatment failures? Right, so there they are. About 5% of all treatments to eradicate group A strep result in treatment failure. Take a point for each one you got right. And then what about tablets versus injections? So here's the last question, question 20. And you're all going to get 100% for this question, because the question is, which one do you prefer to prescribe for your patients with group A strep infections? Oral medications or injectable medications? So if we want Costa Rica's success rate, we have to get 3 things right. Number 1, don't miss the diagnosis of group A strep in high-risk kids. Number 2, treat the patient with the right drug at the right dose for the right time. And number 3, phone the hospital whenever you have a high-risk patient and the diagnosis of acute rheumatic fever looks probable. And when you refer, specifically ask for an echocardiogram on your referral. The Regional Health Pathways and the Heart Foundation website are very clear about this. And which patients should definitely get injectable and not oral? Well, the National Heart Foundation recommends just one, and that's patients who've had 3 group A strep sore throats infections in 3 months. But here's 4 more that you might want to consider. Patients with no fixed abode, patients with no credit on their cell phone because you can't follow them up, patients who have a track record of not completing courses of medication, reasons obvious, and probably all patients who present at emergency departments and the patient has no registered GP, because EDs do not have processes that support follow-up. So if we go looking for high-risk patients, we'll find them. And if you find group A strep, treat it. The risk of acute rheumatic fever after the first attack of group A strep is 3%. The next one is 25%, and the third infection is 75%. And you need to check on your patients to make sure they took the whole course, because we know the default rate can be very high. So we're now near the end of this talk, and there's just 3 things I want you to remember. Thing 1, the Jones criteria. Useful for confirming the diagnosis of acute rheumatic fever, but not very useful for ruling it out. Thing 2, my patients who are at high risk are anyone who's had rheumatic fever before, anyone who's got a family member who's had rheumatic fever, anyone who lives in a house with someone who's had rheumatic fever, or 2 out of 3 of Maori Pacific, 3 to 35, living in an overcrowded house. And thing 3, when a high-risk patient walks into your surgery, always ask, how many people in your house? Have you had a sore throat? Have you got sore joints? Always ask, has anyone near you ever had rheumatic fever? Have you had a rash? Are you tired? Have you had time off school through sickness?
Just so you all know that the 3rd edition of the Aotearoa New Zealand rheumatic fever, rheumatic heart disease guidelines are going to be coming out soon. Most of the chapters are in their final stages. So this is example algorithm 1, sore throat risk assessment, clinical assessment. Obviously unwell, you'd go straight to hospital because you can have invasive strep, but most of the time someone's got a sore throat and they're not that unwell. And so here it has really simplified Barnett's brilliant talk, and I think it was fantastic talk about on all the way to approach things. But it's even slightly more simpler now in this 3rd edition. So either a personnel, whānau, or household history of ARF, and that's because there is one. It was one of the questions on the chat, in the Q&A, was that there's increasing evidence. There's a risk factor for rheumatic fever if you've got a family member. That comes from Michael Baker's risk factor study, and also from the echo screening, we've found that if you've got one family member, you're 2 to 3 to 4 times chance of having undetected RHD. So there's increasing evidence. That doesn't say it's a genetic risk. It's the environment and or some genetic predisposition. Okay, so either the household or age 3 to 35, and actually only one of the following to make it, rather than have to need 2, identify as Maori or Pacifica and living in crowded circumstances, for example, sharing a bedroom, and then we've got in the lower socioeconomic areas of the North Island. So there are 3 factors there. And then I think the green is pretty clear. You're going to take your throat swab, and you can treat straight away with empiric treatment, or you can wait to get your culture back. And then there's a bit about school programs. But next door to it is low risk. If you aren't high risk, you're low risk. And then there's the antibiotic stewardship. You are trying to not treat most sore throats treated by a virus. Antibiotics may only slightly reduce symptom length, therefore avoid antibiotic length. So I think, and then there's quite a nice thing about health literacy. Barnett mentioned the New Zealand Rheumatic Fever Primary Prevention Program from 2012. And what was found from that was, I mean, it's a very strange link, isn't it? That you'd have a sore throat and then you'd be at risk of heart. It's a bizarre concept for people to understand. And so, but that health literacy really increased because of the education and the awareness of the sore throat program. So it went up from about 20% to 80%. So I'm sure you're all getting Maori and Pacifica coming in and saying, my child has got a sore throat. What do I do next, doc? Because their health literacy has increased. But you can check, there's a health literacy approach to check all some of those aspects. There's a nice, this is all in a table, in a long doc. It's a medium chapter, but there's a very nice, much clearer on. You've got repeated, you keep coming back. You have a sore throat, a strep, you give the antibiotics 10 days, and then you get another one, and you get another one, and then there's an algorithm there for the use of intramuscular penicillin and for swabbing between infections and so forth. So I think these guidelines will come out in the second half, hopefully within 3 or 4 months, and I think they'll be helpful. So that's probably all for me, just to really announce the guidelines rather than going through them in detail.
Thanks very much for that, Nigel. And I think it's probably is worthwhile for us to maybe just hammer the point about 10 days of antibiotics, because we did have a couple of questions from a couple of the attendees saying that when they're getting those reports back from the lab with a positive group A strep, the lab report is telling them to treat with 5 days only. But we're still very much emphasizing that it's 10 days. You'd agree with that, wouldn't you?
Yeah, I mean, the evidence, there are studies that show you might eradicate in 5 days, but again, this chapter points out that some of the complications like quinsy and other areas that so I think it's not yet ready to say bland 5 days. That's what the literature is showing at this point. So the recommendation for this guidelines, it might be in 10 years, it will be only for 5 days, but the third edition will say for 10 days for the high risk group if you found a strep A.
We're still wanting to start antibiotics on a high risk group before the swab results come back.
I think that's again where the guidelines are much more permissive here, whereas in the number 1 and number 2 guidelines, it was very saying wait for the swab. But there's a you can go straight to swabbing if you after hours emergency department setting where you think you're not going to see that patient again. Just start your antibiotics.
So it says Māori health provider here, no GPs, nurse-led clinic, rural with a very large geographical area, needs standing orders to allow us to give oral antibiotics without the need to wait for swab results. Our country folk who live 30 minutes plus away from town will wait until benefit day to come back into town, given cost of fuel and limited disposable income, which can be 7 to 14 days after initial swabbing. Easier to say stop the oral antibiotic instead of waiting for them to pick up from the script from pharmacy, and that would be definitely the case, that you would just give the antibiotic before waiting for the swab. But do you have a comment about the standing order?
Well, except to say there are standing orders published on the Auckland Regional Health Pathways for that there. So there are nurse standing orders which cover the whole of the north area. Yeah, so it's Te Taukatumai, Te Tautaukerau, Waitemata and counties, and they've been signed off, and they're visible to any nurse anywhere who wants to look at them. The other issue is that all GPs in rural areas have the rural version of the MedPrac supply order, which includes adequate dose numbers of penicillin tablets or amoxicillin tablets, if that's the choice, or erythromycin if you've got allergies to penicillin. It also enables rural GPs to have on hand, and nurse practitioners, injectable penicillin. So I can't see an impediment to if I've understood that question correctly, I don't see an impediment to the nurse practitioner implementing the treatment that she wants immediately while the patient's still with her.
Thanks for that, Barnett. There's also we also had a couple of questions around skin infections, strep skin infections. And I know, Nigel, you did answer them privately, but I guess that might be a topic that some of the other attendees might be having in their mind. Do we treat strep skin infections with the same level of concern as we would with throat infections?
My colleague, infectious disease pediatrician Rachel Webb, is very hot on this. And she says, yes, of course, you're going to treat the skin infection if it's a staph or a strep. However, it's not yet proven that treating everyone's skin infection will lower the rates of ARF. And that's borne out as well. So it's logical that the strep in the skin could be part of the pathogenesis. But in Michael Baker's risk factor study, only 10% of, or less than 10% of the children in that study of about 150, I think they were in the who got ARF and the controls. The rest, only 10% had skin and impetigo. So it's clearly not going to be a panacea. But going back to what I started with, you're obviously going to treat symptomatic, and also that's health literacy that Barno shouldn't be. That's not. They shouldn't be normalizing. Oh, he's always got skin scores. That's where you can help so much. It's not normal.
There's also a few questions around thinking about risk factors and age. So the low end of the cutoff is 3 years, but would be if a 2-year-old can verbalize that they've got a sore throat, a Māori Pacific, should we be swabbing them, or are they just completely zero risk ARF?
No, there's the old American data was some 1-year-olds getting, sadly getting rheumatic heart disease, but we certainly see children. 1 or 2 of the 150 children a year in Aotearoa we would is a 3 or 4-year-old, but I've never personally seen a 2-year-old. It doesn't mean to say again if for whatever reason they had the strep throat, you'd still treat it again, wouldn't you?
Question, just wanting some clarification about the regime again. So we agree on 10 days. We've got questions asking, should it be given on penicillin be given on empty stomach and QID? Children won't take liquid penicillin, benign penicillin is so painful. So maybe we can clarify for the attendees just an easy to follow regime that they can prescribe for their patients.
Yeah, so the National Heart Foundation guidelines are fairly clear about the dosage of your choice, either oral penicillin, amoxicillin, or in the case of true allergy, erythromycin, and whether the current level of evidence, whether once a day or BD or TID is acceptable. They are silent. Those guidelines are silent on an empty stomach or with food, but that information is available elsewhere. It's available on the New Zealand formulary website. So that's the existing, not the in development version of the National Heart Foundation guideline. But that's pretty clear, really. I mean, it gives your choices: penicillin V orally for children under 20 kilograms, 250 2 or 3 times a day. Over adults, children over 20 kilograms in adults, 500 2 or 3 times a day. And then you've got, with amoxicillin, you've got a choice of once a day, which you don't have with penicillin V, once or twice a day. And you can see the evidence grade on the right-hand side, strong for high and high for all of those categories. And then for those groups that I recommended that you should inject, even if you feel squeamish about it, because of reliability factors, there is the benzathine penicillin recommendation that's third down there, and it's got the doses as well.
I think it just amoxicillin is a bit more simple in the new guidelines. It's just for under 30 kilos, it's just 750 milligrams once a day for 10 days, and then over 30 kilograms, it's 1,000 milligrams once a day for 10 days. So it's made it a bit more simple, I think, for prescribing. Sure.
But the GPs are on this webinar tonight, Marianne, can't see that, can they?
Yeah.
They go into the foundation website, this is what they'll see.
Yeah.
Yeah, which is quite acceptable. I mean, you can go on doing this until the new guidelines visible to you.
You have to.
Both will. You have to, exactly.
We also have a couple of questions around swabbing in low-risk groups. Should we just avoid doing that completely? And what if we've got in a situation where we are having recurrent positive swabs in a family that is low risk?
The evidence is that the low-risk groups don't get the immunological reaction which causes acute rheumatic fever. And so I think that's pretty clear that if they're low risk, we don't have low risk people getting rheumatic fever. So even if they've got a positive throat swab for group A strep, they'll probably clear the strep by themselves. I mean, they clear viruses by themselves, we know, but they can often clear strep by themselves, and it's not necessary to either swab them or treatment. So much so that the laboratory form that I showed you, and I'm not sure it's replicated through every lab in the country, but it's certainly in the north. The lab is sending a very clear message to not do throat swabs on low-risk groups, because the only group that it really matters is the high-risk group.
Mm-hmm. And I think certainly in my practice, I think you do sometimes reach that dilemma where perhaps you've got a low needs population who hears all the messaging around rheumatic fever and perhaps sometimes mistakes themselves as being in that high risk group, and having to have those kind of somewhat challenging conversations, but actually you are low risk. So we would be less likely to want to swab and treat you empirically. Any thoughts on how to navigate those kinds of conversations if you've got anxious parents, worried that their 7-year-old's going to catch rheumatic fever from a sore throat?
I think you've just given the answer. You educate. It's about health literacy for everyone, for them as well. There's a little paragraph in the new guidelines saying, in the low risk group, there are still some people at high risk of spreading strep A, such as health workers, school staff, food handlers. So there are some people with their lifestyle you could rationalize giving an antibiotic that come up with a sore throat, and it's stop spreading.
Mm-hmm. We've also had a question come through on a patient if they're already on monthly penicillin, the presumed previous rheumatic fever, and they're coming back again positive for Group A strep. Is there any change in the management plan for them? Are they special cases?
I'll just put a slide up that covers that. So the answer is it depends. So this table we just looked at is for first and second episodes of sore throat. This is for third and more within 3 months. So I didn't quite nail down the detail in your questionnaires question, but I mean, I'm assuming they're asking, here's a patient already on prophylactic penicillin and they get another sore throat. Is that what I'm hearing?
And they're positive for Group A strep here.
Yeah.
Do you want me to answer that? Because
if
it's a patient who's already on the rheumatic fever program, like having 4 weekly penicillin injections, and they get a sore throat and it's positive for Group A strep, then they still need to be treated with an extra 10 days of amoxicillin. Continue the 4 weekly penicillin, but have treatment, a 10-day treatment. And then if they continue to have breakthrough Group A strep, asymptomatic Group A strep throats, then sometimes we will push back the injection program to every 21 days. It's very rare that we have that, but we've had just a couple of patients that end up, when the injection maybe starts to wane after the 4 week, you get to the 3-week time, and they might be a little bit more susceptible to a Group A strep infection, and then we may push that back to every 21 days. It's rare, but that could be discussed if that was a break, if that's what the person means by that. Yeah. The other thing is if it is a symptomatic sore throat, so it is an infection, it is treated, definitely swab the other household. We just had one recently that we had exactly that scenario, and they slept in the same bed, sometimes at a cousin's place, and all 3 children had Group A strep infection with sore throats. So we treated the family. So there was a bit of bouncing around as well. So just to be aware of that. Yeah.
We're also having just a question about, can you have strep colonization of throat in some people? And they're just talking about just straight up colonization without necessarily any symptoms.
I mean, the answer is yes. There are people who are asymptomatic, and you can repeatedly swab their throats and grow Group A strep, and they remain asymptomatic all the time. So neither do they get the invasive version of strep, nor do they seem to get the antibody reaction, but they are carriers, and so potentially the case that Marianne or Nigel mentioned with health workers, they provide a risk to people who are vulnerable, who do get the antibody response and develop acute rheumatic fever. But if they weren't in that situation where they were going to spread it or at high risk of spreading it, it would be hard to justify treating an asymptomatic carrier state, because I mean, you could talk to your pathologist about this, your microbiologist, but I would suspect that the answer will be that the risks to the antibiotic stewardship, that is developing resistance unnecessarily, would be a greater risk than there would be any risk to that individual or the people immediately around them if they're not at risk either. I mean, it's not an easy one to answer, but everything in medicine is a balancing act, isn't it?
There was also a query around ethnicity data in terms of, is there any ethnicity data on children from other ethnicities apart from Māori Pacific and their risks of rheumatic fever?
So, Marianne, you can tell us if there's been a case of a non-Māori, non-Pacific kid coming into Starship needing valves. I don't know.
It's definitely, Nigel's probably better than me, but we do have the occasional one, but I would say it's 95-96% are Māori or Pacifica. We've had some Southeast Asian, Philippine. Actually, we had a Philippine child today. We saw her in clinic, and I do know of a Philippine child that had double valve surgery a couple of years ago. That was about 10 years old. So, but really, isn't it, Nigel, that we would have someone outside of that population group?
Yeah, absolutely. About one or two. Yeah. And I think that just raises the question. There's so much we don't know about this disease. And, we don't know why only a small proportion of those that have a strep throat go on to get rheumatic fever. It's an immunological response. So I think always saying to whānau, it's not your fault, that your child got picked out to have rheumatic fever when the next door neighbor or the sibling didn't get rheumatic fever from the sore throats. And Pakeha used to get rheumatic fever. And that goes back to, socio-economic deprivation and housing. And we know again from the University of Otago, Michael Baker's group and others, Philippa Howden Baker, that, if everyone had a warm house and everyone had their bed, you would that alone would dramatic prevention, and in the sore throat chapters of the new guidelines will be links to referring for housing for housing assessment, which has been a big part of the ministry's attempts to reduce rheumatic fever, and appropriately so.
But just to add to that, I mean, certainly across the ditch, the Aborigines and Torres Strait Islanders have equally high rates as Maori and Polynesian and Pacifica do in New Zealand. So it's as major an issue for them as it is for us. I think the problem for New Zealand practitioners then is that if someone comes in from the Philippines or Pakistan or the Middle East, and we don't know whether that's a high incidence country, then what level of suspicion should we have? Should we treat them as high or low risk? And that's difficult to know. But if you look at the WHO data for the number of cases of acute rheumatic fever in the world every year, it's in the millions. So this disease has not gone away. It's just that some countries like Cuba and Mozambique managed to, with force of will and a very rigorous approach, both public education, health education, physician compliance with rules, they've managed to eradicate or nearly eradicate it. So we know it's possible. And Nigel's point is, I think, is paramount really, and that is if you increase the socio-economic status of patients, especially if you give them warm housing and give them their own bed, you could everyone their own bed, you could lower the rates of acute rheumatic fever dramatically.
Good response. I think we literally have a minute and a half left, so I think we'll do one last question. I think an interesting point, what about vaccines? Is there any research going on? Do we know, is there anything in the horizon in that space?
I could answer that. So I've always say when I lecture, it's always 10 years away, greater than 10 years away, but I think we are finally under 10 years away with a coalition of Australia, New Zealand, and other international players, a consortium. They've really moved a long way to getting a vaccine. There's a number of candidates, and I think we will be seeing this within 10 years now, finally.
I'd just like to really extend a warm thank you to our three panelists for tonight. It was an excellent talk. I think it got a lot of, we had a lot of stimulating discussion after the presentation. So a big thank you to the panelists. So yeah, thank you so much for attending tonight's session, and we'll see you next time. Thanks a lot.